bees and squirrels. No.
She won't be here long.
Hello. Hi. Hello. I think that baby would like to talk oral health. I think the baby would like to talk about social emotional health as well. Oh, I see Dr. Janie Savage coming on.
Is that naturally curly hair?
Oh, yes. She came out with that much hair. Yeah.
Oh.
How old is she, Laura? Like 18 months?
She's 8 months.
8 months, not 18. Geez, my eyes are not working for babies.
Well, her dad is 6'4" and 300 pounds, so she's good size, huh?
Oh my goodness, to be over 6'4", man, just to be over 5 feet would be lovely. So there we go. We all know Lisa's not over 5 feet now. Let's go ahead and start QHOC Quality Health Outcomes Committee meeting. Welcome to 2023. Looks like Jeannie Savage is on, so we can begin. Welcome. I am Lisa Bowie, go by she, her, hers, dark black hair. We are gonna get this meeting going. Thank you. If you were going to the QHOC website, I believe OHA was having some issues with our website, so there may be an issue with information being posted. We are working on that as of Friday evening. I'm not sure if it got straightened out this morning, but materials will be posted if they are not. So hang tight on that. Maybe
The slides are there, Lisa.
Perfect. I know
Yep.
they weren't there Friday night. We were working with some tech people. So we'll go ahead and go through the agenda here. Just as a reminder, when not speaking, please remain muted. Please raise your hand function and or use the chat function. You should be able to chat anyone and everyone and or myself. And then if you can state your organization when you start to speak, that would be very helpful for all those that are on the line. Just a review of the agenda, do some announcements. I'll go over the retreat review from December and kind of talk about where we're going. We have a few HSD, Health Systems Division Medicaid updates, pharmacy and therapeutic updates, ESPDT, just kind of a general check-in. Then we'll take a break. We'll go into the HERC update, and then the last part will go into some breakout rooms to talk more kind of operational small groups in what you all are doing around EPSDT. Next slide. Just some general announcements. So just as a reminder, there won't be a QPI session this morning. Laura Matola sent out a message, I think on Thursday. So I'm just going to cover a couple QPI, quality performance improvement announcements. The initiation, engagement, and treatment, IET statewide PIP. I am meeting with the HPA analytics manager, and we will be discussing that statewide PIP data on January 25th. So I will be getting an update on the ETA estimated time of arrival for that baseline data. So I will be sending out an announcement, or we'll be talking about when that baseline data ETA might be. So there will not be a January 31st quarterly progress report for the IET statewide PIP. The mental health access statewide PIP quarterly progress report is due along with your two other CCO specific quarterly progress reports. So the CCO specific PIP topic areas, along with the mental health access statewide PIP quarterly progress reports, are due on the January 31st. A reminder, there's a TQS Real D Part 2 webinar. So we had a TQS Real D webinar, I believe in December. We added one just as a continuation at the request of CCOs. So we're going to have another Real D TQS webinar. It's on January 23rd at 2 p.m. So just a reminder about that. And then CCOs can submit a singular TQS project for a pre-review for technical assistance before February 15th. And then there's that email to submit that. Any questions about that? Next slide. Okay, I am going to go ahead and do a quick poll. So basically from December, we did a breakout room and conversations about where are we going in 2023. So coming out of the pandemic, last couple of years, we did a lot of discussion about where's COVID, what's COVID, all the COVID updates, what kind of overtook a lot of QHOC. We also did a lot of coming through what does QHOC look like with COVID, what is bringing learning collaborative slightly back into QHOC. So in December, we did what does QHOC look like in the post-COVID world. And so these are the key questions we discussed. What goals and objectives would you add, adapt, or change? What clinical and quality priorities would you want focused on in 2023? Who's not being represented at QHOC? And any learned collaborative topic suggestions that would be done here at QHOC. So those are the questions that we did in breakout rooms. And so I'm going to I synthesized the breakout room discussion notes. Thank you for those that shared the notes. You all took great notes. And so I synthesized.
Lisa, you went on mute spontaneously, which was quite a trick, actually. Can you teach me how to do that with my children? I need that trick for teenagers.
With or two?
It's a very good question.
I don't know. Somebody must not have liked me and muted me. I didn't.
Go back. Go back about 30 seconds. I think you said you finished saying learning collaborative topic suggestions.
Oh,
this is what we're going to review.
And then I said the QHOC chairs and I met, and we were going to. I'm just going to cover what we talked about, and I synthesized it and put it in the next few slides. One of the things also that we did was a poll about meeting frequency or meeting format. And so we didn't get a lot of results because we did the poll at the end of the meeting. So I'm going to put a poll up right now, and I'm going to let that poll run. Let's see how many participants. Oh yeah, we got about 50. I'm going to let that poll run while I'm giving you the summary. And then I'm going to close the poll before we go into the P&T. Or before the next update. So I'm going to let the poll run while I'm talking. So I'm going to hit the poll button. I think I can launch it, and it's just going to hang out while I'm talking. So you should see a poll that's just hanging out. So I'm going to go ahead and go next slide, please. Here's some of just candid comments, good, bad, and ugly, that were just throughout the notes. Sharing best practice is great, but because we have a lot of aspirational goals in the waiver, I wonder if we could add pilot projects and innovations. Intentional questions solicited ahead of time would be great to support engagement and dialogue. How are we meeting this? Shared ahead of time. What's the new normal? So what does this look like? What does this meeting look like post-crisis? So, the last few years has really been COVID. What do we want for collaboration? To that point, we are focusing a lot on data, but what are we doing with this data, and how do we focus on that? Metrics. We need a dialogue around metrics in real time through implementation. How do we approach things when things aren't going well? The only place for feedback is with our own providers, and then letters to metrics and scoring. But this meeting should be a place for that. things used to be collaborative, in person, and things have changed over the last 3 years. And again, we kind of highlighted that this meeting, especially the last 3 years, has really been kind of, well, a lot of our lives have been really crisis management with COVID. So how do we think about that going forward? Next slide. What clinical quality priorities would we want to focus on? So these were in no particular order, and there were themes across each one of the breakout rooms. So the good news is we had consistency, and we had a lot of duplication across the different work group notes. So that's good. We're all thinking some cross themes across the group. So 1115 waiver, we heard about that. We heard policy areas that are in those waivers. We heard health equity. We heard behavioral health integration. We heard SDOH screening. We had SDOH, HSRN, health related services. We heard MEP. We heard access, reproductive health or health integration, consultation on key contract deliverables, HIT, community information exchange, health information technology. Just wanted to make sure I called that out if you didn't know the acronym. Consultation on the equity strategy and the health equity plan specifically. Learning collaborative topic areas, the QHOC, known as the Quality Assessment Performance Improvement Deliverable, and then specific actual metrics that are incentive metrics that the CCOs are working towards, known as meaningful language access, social emotional health metric, and the SDOH metric. Let's see here, the poll popped up and then it went away for some. Is that what I'm understanding? Well, it's still showing active. Let me see how I can, it just shows that I can end it. So I'm not sure.
Is there a link, Lisa, that you can post in the chat for people who for whom it didn't pop up? It looks like Andy wasn't able to, it didn't pop up on his screen. And there's another question, Lisa, about location of meetings, and I didn't know whether that was something that you would like to address.
I saw Jeannie replied, usually they're in Salem. Salem is the for this particular meeting, usually it's in Salem because one of space, like the room that we need for the size of the type of the size of this QHOC meeting is larger usually. And so the HSB Human Services Building, Barbara Roberts, 500 Summer Street, that's been the regular meeting space that QHOC meets at. Next slide. I don't know how to do the poll thing other than it just lets me do end. So we might have to make a Survey Monkey, I guess. Andy, what you could do, I guess, let's see here. Let's see if I can. Jennifer, could you just put people, the options are virtual only, hybrid once a quarter, hybrid every other month, hybrid twice a year. So twice a year in person, every other month in person, once a quarter, or virtual 100%. So if you want to just put in the chat which one you like, ideally, you only get one vote. So if you could just do that, that would be preferred, please.
Lisa, can we see how many people responded to the
20.
poll so far? Because in which case we
26.
probably could end it and then do it again and see if you got more responses, or maybe show the results now, end it, and then say we're going to put it out there again. And when you put it out there again, everybody can just vote again and see if we get more than 26 responses. I've done that in the past when my polls have gone awry.
Okay, let me see if I can end it. It's 26 right now. I'll end it and see what happens. Share results. And then let me just relaunch poll. I'm gonna relaunch it right now. Everybody ready?
Lisa?
It's relaunching. Yep.
Hey, Lisa, this is Bhavesh. A quick question on the hybrid meetings, and then once a quarter or otherwise in person. The in-person time, will there also be virtual available during that time? In other words, the in-person time will also be available as a virtual for some if you want to.
I would expect that we would still broadcast, you know, for those that can't make it in person. Like,
Good.
Like, we would still, you know, Teams or Zoom it away to whoever can't show up.
Very good. Thank you.
Yeah, I would stress though, I think that in what I've seen in other areas is when we do that, you tend to get less engagement in person. So I would really stress that while it is an option, I would love to have people, if we're only going to do it quarterly, it would be great if people would really show up in person so we can get that connection and FaceTime.
We're going to structure the agenda that it's going to be focused more as an in-person didactic type of learning versus virtual though. So to Bhavesh, to Jeannie's point, but we're not going to, like, you know, close door and not put a, you know, a camera in and a virtual, you know, we're not going to, you know, not set up a phone line or something.
Yeah, I just wanted to clarify for folks that were thinking virtual only, not being able to go for whatever reason. So that
Yeah.
could still be an option for folks otherwise. Thank you.
Yep. And we did that even when we were in person, you know, we still, you know, still broadcasted it. That's why it was such a lovely technological fun for me.
Did everybody get the poll, Lisa? Can we just check?
Let's take a peek. We still only had 19.
Y'all
Lisa,
can,
oh,
David, did you get the poll this time?
I did. Question, if we voted the first time, do you want us to vote the second time or not?
Yeah, I mean, technically, I can announce, I mean, we still have less people this time than the first time.
Okay.
Yes, everybody should vote again because your last one is null and void, really. That only
correct.
goes with that one. You need to vote again. Everybody needs to vote again.
In
Lisa,
fact,
this is Dana.
Holly Joe
Can
just
I email
joined.
you my-
Who was just talking?
Sorry, this is Dana at Willamette. I was just wondering if we can email in our vote if we've called in.
Yes, you can, or you can put it in the chat log.
I'm on the phone, so yeah.
Oh,
I'll
yeah,
email
you can
Thank
email me. So some comments that came in were virtually, monthly with quarterly in person. Again, if it is quarterly in person, we will still have a, you know, Zoom link. Workshop style for longer engagement to do deeper thinking, hybrid meetings without camera, breakout rooms to help with engagement, break QHOC into an update portion, and then, you know, some type of engagement. Again, the actual kind of breakout rooms or polls. Next slide. Just general thoughts, kind of somewhat similar line, structured breakout rooms, but also more integration of oral health, social health, community-based organization representation, the kind of lessons learned from COVID. How do we bring in some of those content expertise, behavioral health? How do we integrate more from the behavioral health side, as well as the behavioral health meetings and CCO directors? So these are just kind of some just general practices and thoughts that your chairs will be working through in how to bring these thoughts into the meeting structures and or format. But that's what we heard from y'all. Questions, thoughts, comments, additions? I'm ending the poll. I always love to see how we get data and it's always split. It's just the way it rolls. Guys are consistent every time I take a poll. Next slide, please. I think before we go to Roger, you don't get to jump too quick, Roger. Dawn has just a few updates on the agenda. Dawn?
Thank you. Good morning, everyone. Happy New Year. Dawn Mautner. She, her, Aya, white woman, long dark hair, new red fleece, and I serve as the Medicaid medical director for this state. The updates I want to share with you reflect the work that you are doing on the ground in terms of implementing two things. One is the COVID vaccine coverage, and the other is palliative care coverage. COVID vaccines have been, as you know, provided by the federal government at no cost. And with that, throughout the pandemic, we have had a greater network of vaccinators than we typically have with, for example, the Vaccines for Children program and ongoing immunization programs. And what is going to be happening on a timeline that nobody has been able to share is that the federal government will stop providing COVID vaccines at no cost, and we will be transitioning to the standard commercial methods. So the cost of the COVID vaccine right now appears to be running about $125 a dose, if I understand it correctly. And we already have the codes in MMIS for administration, of course, but we'll be getting the codes in and up to speed. But that I just wanted to be sure that everybody is aware that that transition is coming, and there will be more to come about it as we get more information. Questions about that at this time? Seeing none and hearing none, I'll share the other update, which is not very much of an update. There was a memo that went out in December about a palliative care program coverage as a result of House Bill 2981. It is linked in the agenda, and some questions have been raised about it. For the most part, Medicaid already covers palliative care, and my sense is that we don't expect a huge amount to be changing with this, but that is not thoroughly established with all of the subject matter experts at the state. And so for right now, I wanted to address the fact that this memo has gone out, and also address the fact that our subject matter experts have not been able to provide me with all the details that you may wish at this time. So we will be following up on that at a future meeting with more details. If you have specific questions about it that you wish to share, please go ahead and drop those in the chat or share them with Lisa or any of us after the meeting, and we will address them specifically. That is all I have at this time. Questions
Thank you, Dawn.
about that? Seeing and hearing none, I will pass it on to Roger.
Good morning. Can you hear me okay? All right, thank you. Roger Citron, he, him, Director of the Drug Use Research and Management Program, bringing you an update for the last P&T committee meeting we held on behalf of the OHA. The meeting was held on December 1st. Next slide. The recommendations were submitted to the director of the OHA before Pat left, and those were approved. Here's a link to the website where you can read those recommendations. The YouTube recording of the meeting and minutes will also be posted in the same location. And those were approved on December 8th. Next slide. As part of the meeting, we have a standing consent agenda where we look for oncology updates. We add new drugs to our policy. There were three new agents here that were added to the policy. The link on the bottom of this page goes to the PA criteria on our searchable web application. Next slide. Also part of that consent agenda is the orphan drug policy updates. One new drug, Pedmark, was added to that policy. Again, linked to the dedicated PA criteria and class for the orphan drugs. Next slide. This was a DUR focused meeting, so we did a drug use evaluation to look at polypharmacy within the fee-for-service population. We really didn't find anything of great concern that warranted us changing any of our policies. If you're interested in the details, I've actually put a link here to the packet of materials that we presented that includes the DUE, and that can be found on page 48 in that packet if you want to see the data that we pulled and the results. Next slide. As you're all aware, we are now, as of January 1, have incorporated EPSDT, early and periodic screening and diagnostic and treatment, into our PA criteria and our evaluations. And so we made some examples and talked about the policy with the P&T committee. So this is for members that are under 21 years of age, who previously, when we looked at something was an unfunded diagnosis, we need to take that further step to have a case-by-case evaluation for the member and determine whether or not the request is medically appropriate and necessary. And so some of those criteria will be that it's FDA approved or compendia supported for the medication. Explicitly, we're saying if it's in a PDL class where there's multiple alternatives, say, for example, that are preferred, that we'd like to see a trial and failure or contraindication to at least 2 of the preferred products. So it's kind of explicit step therapy that we'd incorporate with this policy evaluation. And then documentation that the disease is of sufficient severity that it's impacting the patient's health. Next slide. Based on some updates from the Health Evidence Review Commission, we looked at the growth hormone PA criteria. We updated our coverage guidance, and there was a new FDA-approved indication that we included. We did review the drugs in executive session, and the recommendation was to make Neutropin AQ non-preferred. Again, search a link to our searchable web app, so you can go to the growth hormone, see our review documents, and also dedicated PA criteria. Next slide. We looked at drugs for asthma, COPD. We didn't have any changes to recommend based on the clinical evidence, but we did update to align with current guidelines. We retired the ICS LABA PA criteria, and for that class, we'll subject the non-preferred therapies to our general PDL non-preferred PA criteria. We reviewed costs in executive session, and we recommended making Spiriva Respimat preferred. Next slide. Influenza class update. Again, no changes were recommended based on the clinical evidence. We did update the PA criteria with the expanded indications and ages for perimivir and baloxavir. Looked at comparative costs once again, and no changes were recommended based on that review. Next slide. So for the topical products for inflammatory skin conditions, HERC had performed a lot of updates and review. Their coverage guidance for vitiligo or for the hand, foot, or mucous membrane involvement. We memorialized that in our topical agent PA criteria. We included ruxolitinib and for patients that were 12 years or older based upon its indication. Designated Zorv and Vitama non-preferred, limiting them to their FDA-approved indications and ages. And so again, if you haven't looked at it already, some of the HERC guidance for plaque psoriasis, again, that hand, foot, face, or mucous membrane involvement. And also for members that have an inadequate response to at least 2 moderate to high potency topical steroids, again, for 4 weeks of treatment. Next slide. Continuing on with the topical products, we updated the PA criteria to incorporate individual review. Again, this is a recurring theme with EPSDT. When you look at our packet of materials, you can go look at EPSDT. Again, from pages 64 through about 91, we have about 10 different examples of PA criteria and how we folded the EPSDT review into those evaluations. So in this case, for the topical products, we explicitly called out those changes to the criteria. We combined the topical antipsychotics with the agents for inflammatory skin conditions. So we just had one criteria. looked at cost in executive session, and made tazotaritin gel non-preferred. And that was all we reviewed in December. Next slide. The next meeting of the P&T committee is going to be held in February. It's slated for February 2nd, again, 1 to 5, being held virtually. The agenda and all the final materials were posted last week to our website. I invite you to go take a look at those. It's open to the public, and we welcome public comment. And this is a link to our website, again, where you can find those meeting materials. Next slide. For those of you that have listened to me the last year and a half, you'll notice that now I'm omitting a slide requesting members that might be interested for appointment. I am very happy to announce that we found 2 physicians willing and able, and were appointed to join the P&T committee. So we'll have a full slate of P&T committee members, 11 members, for this February meeting. So thank you very much. However, if you still are interested in being considered for appointment for future years or for the Mental Health Clinical Advisory Committee, I invite you to reach out to myself or to Trevor Douglas, and we'll direct you to where the application is housed, so you can see what that entails if you're willing to take on that important work. So with that, I'll take any questions.
Yeah, hi, Roger. This is Jeannie Savage.
Yeah, Jeannie.
Just a quick question. So in review of a lot of our overdose and overdose prevention work, and looking at the issue we're seeing with combined substances use, a lot of opioids as well as stimulants being combined now with, oh gosh, the kitchen sink, it seems like there's a lot of different things being combined now for that we're seeing in overdoses. I'm wondering when the last time was you and your group have done a review of the stimulant prescription pattern or use in our state, putting together maybe the CCO data that we give you and the data that you have from your fee-for-service population, maybe, you know, not just Medicaid, but overall, what kind of prescription patterns are we seeing in that stimulant area of the stimulants, and are there any changes that the state could make or look into in the interest of decreasing the amount of stimulants that we're putting into the hands of the public for, you know, any overdose potential?
It's a great question, but really not a focus of the P&T committee or our work on behalf of the OHA. We really focus on the fee-for-service population, so we have not rolled up the CCO utilization for stimulants. You know, we do look at the class, particularly for the fee-for-service, because this is a unique class where some of the carve-out, the non-stimulants, Strattera, Cathay, and Tuniv, are carved out. But more broadly, you know, we have some internal reports where we can see where some of the utilization is, but not more broadly. We don't have access to the PDMP as some of the CCO directors have, so they can see, you know, if there's cash paying going on it. It's a brilliant question. I thought you were kind of touching on one of the subjects we have at the February P&T meeting. We'll be looking at medications for substance use disorder and then opioids and alcohol. So it's kind of touching on the, I think you're bringing in the stimulants as well. That's a special component of that. You know, we have pretty strong restrictions right now with opioids, make sure that we have the short acting before the long acting. I think in the criteria that we're proposing, you know, asking the question, make sure members have access to naloxone. But it doesn't get to the level that you're doing. It seems like this might be something more broadly that we could collaborate, right? QHOC and some of our data. It's rather delayed. If you look at from the fee-for-service, we might not see it for 6 months or more. That's why our reporting is so far out. There's a long-winded answer to say no, we haven't done a deep dive in that area, but I think it is important, probably something that we would want to incorporate public health on as well. I think they would have some great input for that. And, you know, maybe there's some opportunities with all payers, all claims. It's not data that I've worked with particularly, but I think there could be opportunity there.
Yeah, I think that that's a really fantastic idea. Clinically, it seems like there's been an epidemic with adult ADHD. I know that the Center for Evidence-Based Policy had done a lot of work on this previously, but really understanding how that's appearing in, you know, across the board and across the state, to understand if there's how that prescribing is looking over years, I think would be a really important analysis.
So
Agreed.
if
Thank you,
I'm,
Kat.
yeah, so if I'm hearing you right, Roger, then it's not something that your group would spearhead, correct?
We certainly could play a role. We have a DISCERS, and we have data that we could pull at the direction of the OHA to bring in data. We've really focused on fee for service where we have opportunity impact. Our utilization controls have no bearing really on the CCOs and what they're doing. So I think there's an opportunity to collaborate.
Okay.
Both this group and maybe something that, formulate what that ask is and maybe collaborate with the CCO pharmacy directors. They meet in the morning on the same day we have the P&T committee. I think it would warrant further investigation. So I appreciate the question and Kat's input as well.
Okay. Lisa, go ahead. Sorry.
Oh, no, not sorry. This would be one of those, I think, Jeannie, this would be one of those conversations you'd want to formulate kind of, I guess, at the backside of it would be at COMED to think about the idea. We would want to talk at the QPI session from the data side. You guys would talk about the clinical COMED side on the clinical side, but then we would want to go circle back with the pharmacy team, right? But then what I would do is, I guess I'd be that connector piece. We would have on our side a group that isn't necessarily as coalesced. We have a different side of it that's coalesced post-COVID, but we used to have a group called like the Opioid Initiative that had different policy makers, data people, the HERC, public health, because Roger just referenced like we'd want to get our public health folks, our data folks, and I was in that as a, I guess you could say, a connector piece, and I would get the ask, like Roger just said, the ask. This is the ask of the CCOs, and that ask is very clear from the CCOs. When I say the CCOs, I mean not just your medical people, but your pharmacy people and your quality people. So the ask is very kind of clear of we know what we're looking at it from the data side. So when we're taking it, whether we're taking it from APAC data, whether we're taking it from our just our Medicaid data sets, because there's a whole lot of data we got in a bunch of different sources, and we need to be clear where we're taking it from and what we're taking it from and what we're looking at it from before I start, 3 different rabbit holes. And so
yeah, no, I
being
hear
clear.
you.
And so
I hear
we
you.
can definitely explore those conversations. And so if you take it to the COMED, I take it to the QPI, we circle back with the pharmacy group through D. Weston, and then I take it through into the opioid initiative group to say, hey, the CCOs have expressed wanting to partner on X, Y, and Z for the purpose of this. Where does that fit? Then that seems like a reasonable thing. Next steps.
Yeah, that sounds good. And I think for the takeaway, kind of the overall, just to step back for a minute, that got really weedy, which I when you start talking data systems, I start going, oh gosh, where is that? So, but I think the overall ask is kind of like we did with opioids, right? So how is the medical community contributing to the problem via data? How do we identify how the medical community is contributing to the problem? And then how do we look at that in a way that's member focused, health focused, high quality focused, in such a way that we address the issue, which is that we have a lot of Oregonians dying from polysubstance use. And we've really focused on opioids, and we know that we need to focus on alcohol. And I think the trifecta, or that third part of that stool, is the stimulants. So I think the overall ask is, how do we work together to open that and have those discussions? And I can definitely go to COMED, you can go to QPI, and you and I and Dawn can have this discussion. It came up very organically in my mind.
And we have to come, and we have to bring our public health partners to that conversation. And then
absolutely.
And then our addictions, John McElveen, would want to come to the table.
I think organizing a group to really Yeah, totally. I'm all in. So we can have that discussion and figure out how we can bring it back.
Yep.
Happy to be part of that. And I think collaborating and finding best practices, you know, we certainly require PA for the opioids, probably could do more for the preferred stimulants. You know, we can have some edits where we're looking for combination, but a lot of things you don't see without the, you know, access to the PDMP. Certainly don't see alcohol. So a lot of opportunity in this space. Great idea.
Definitely. I hear coordination a coming.
Definitely. Thank you for the opportunity to present today.
Dawn, next, there isn't a slide for you, but you are going to field just on kind of the policy side of EPSDT, not kind of the conversations where CCOs are going to go in the breakout room, just policy side of EPSDT.
Thank you. Thank you, Roger. So we know that everyone is implementing EPSDT now, and a lot of things have been done to smooth that transition, including expanding coverage through the prioritized list, moving things above the line as appropriate. And we know that, for lack of a better term, handicapping malocclusion, HCM, is of great concern in great measure because of the lack of workforce to serve the need across the state. And I trust that our partners here are looking to the CCOs to see how you can help us help solve that problem in terms of building out that provider network for adequacy, but wanted to open the floor for a few moments to field any questions that you may have about that we might be able to handle from the OHA side. Hearing none, seeing none, I'm glad we've got that solved. Next item. Hearing none, seeing none, acknowledging that there are many questions out there. If this is not the right place and the right time, we look forward to continuing those conversations, especially as we hope to get a dental director on board at the state. We do have some dental professionals participating, certainly, to help guide this in the right direction. And if there are any others who wish to chime in with things that you know, I would welcome that as well.
Dawn, I think there's some comment in the chat, and I'm not sure that we the agency can answer that, but need better guidance on ortho benefit. Can you clarify medical and dental necessity? And I think, I know you've referenced needing an actual dental director, but I just thought I'd put that question, since it actually is in the chat, but make sure you saw it.
Thank you. We will be doing some work to refine and rework the medical necessity definition this year, early this year. And I would welcome the EPSDT staff policy. I see Laura. I don't know if we have Jessica or Liz on the line.
Jessica's on.
Jessica is our EPSDT policy analyst at HSD Health Systems Division. Dr. Meg Carey has posted in the chat the specific rules that we do have at OARs listed in the chat. And Jessica, do you have anything further to offer?
Excuse me. Thank you. Yes, medical necessity and medical appropriateness are defined in OAR. Dental appropriateness is also defined in OAR. We will be reviewing those this year to make them more applicable to EPSDT. They will be going through the RAC process, and so will be available for public comment at that time.
Bhavesh?
Yeah, in regards to that, I think one of the things that I was concerned about, the conflict between a provider saying this is necessary for this child's future well-being and it being the condition being so mild that it wouldn't normally be a covered benefit on a previous guideline note. So for example, acne, mild acne is not a covered benefit based on the guideline note and would fall below the line. But if a provider were to write, well, this will affect this child's future emotional state, where do we stand with something like that? So I'm looking for clarification how the guideline notes play in when we look at mild and moderate conditions, which otherwise would not be covered. Thank you.
So the guideline note still applies. They have not gone away, as well as needing medical necessity and appropriateness. So they would need that review. Also, they would need the individual review and to see if for that individual that would be medically necessary and appropriate. It may not be for that individual. However, for another individual, it could be. It really needs that individual case review.
Yeah, this is Jeannie. Bhavesh, I see your hand is still up. Did that answer your question or do you still have, oh, it's gone.
Yeah, no,
Okay.
we're good. Thanks.
Okay. Yeah, I think the difficulty lies in the perception of the provider, the member. What one person may say is minor feels to somebody else very major. And so, this is the difficulty in making decisions around care and having limitations in that not everybody will be able to have braces now that this is happening. It will still need to be, because of limited resources, it will still need to be provided for children who have severe malocclusions. And I think depending on where you're sitting in that, this is a very difficult way to go forward. And I think previously it was somewhat more clear. Difficult decisions still need to be made. But now moving forward with this, it's the perception and what a provider writes as or sees is, even if it does not meet the degrees of malocclusion, if it's affecting that child in a way emotionally and behaviorally, et cetera, going forward, it's going to be very difficult to say that that isn't a major issue for that child. So I just want to acknowledge that this is very difficult on everybody's. I think all of us would say, if you need braces, let's get you braces, right? And I think most people would say, if you have a bad malocclusion, let's treat it. But I think we have limited resources, and going forward, this is going to be very difficult. It's going to take a lot of open discussion and a lot of working together on each case with our providers, the limited providers that we have, and with our members. So it's not going to be easy, but ongoing discussion and openness and transparency will be helpful.
Thank you, Jeannie. Jessica, I'm just going to read something that's in the comment. I'm not sure if you're able to see it. If an EPSDT denial should go to hearing because the CCO determined medical necessity and appropriateness are not met, how do we handle that since ALJ is not clinical?
So the hearing process has not changed and will still remain the same that we already have in place for non-EPSDT services. So they would that would be the same process. And something else I just want to say that Jeannie mentioned and just follow up with. Part of the difficulty, I think, for Oregon to implement this is to remember that we are the only state with the prioritized list. So we had to do a little bit different implementation. And so I think that's some of the angst with some of this maybe. But 49 other states and Washington, D.C. have already implemented EPSDT. So using these same standards. So we are catching up and, you know, the work the prioritized list, the HRC has done for the prioritized list has greatly helped that process as well.
And speaking of the HRC, Ariel.
You're still muted, Ariel. You might be double muted phone and computer.
Can you hear me now?
Yes.
Okay.
We didn't hear anything from the beginning, though.
No worries. I just wanted to sort of share. The HRC has assumed you've been doing a lot of this work already as part of the exceptions process. So like with the example of mild acne, if you had a kid with severe depression and treating the acne might help the depression, you would pay for, you know, it. So there's already been some of this kind of baked in. So hopefully this isn't kind of all new. That's all I had to say.
Thank you.
I think that's, this is Jeannie. I just think that, I mean, I hear you, Ariel, and that's true, but I think specifically for malocclusions, there's a different, like mild acne, treating with a medication like, or, you know, covering certain medications over the counter or doing things like that, that might help, or a treatment that may help depression for mild or not severe acne is one thing. But I think malocclusions kind of is a completely different aspect. If you start to look at the gray area on the ones that clearly meet, no big deal. Like those should be covered and they'll be covered. The ones that are on the side of mild to moderate, but have emotional impact, that is where this is going to be difficult to apply, and where I think we need to start looking at the impact of the cost as well. Will start to hit our limited resources as a state for a Medicaid budget.
Thank you for articulating those concerns, Jeannie and others. They are real concerns. We know that that is taking some time to work through. We appreciate the partnership and collaboration and working through them together as we catch up with the rest of the country and bring our broader, more comprehensive support of kids and youth into alignment. I see a question in the chat about, are there any lessons learned, best practices from partner states that we may have, or an avenue for CCOs to share and learn? Jessica, can you speak to that?
Sure. Yes. And so I meet every other month with the other EPSDT people, such as myself. Each state has either one of me or a team. And so we have an opportunity to learn from other states. And learn best practices and or areas in which have not been so successful. And that is why we have worked so diligently to communicate and work on communications with everyone about EPSDT and getting services out and information about services and what this expansion means, because that seems to be an area in which other states ran into some trouble. And we had some catch up to do in Oregon, to quote Dr. Don, myth busting. But and some other areas, we are unique and not the only state, but not all states have managed care and fee for service. Oregon does have that. And so we are unique in that area. Some of our counterparts, Colorado and Maryland, tend to have the closest systems to what we have. And so I have worked with them to learn what has worked with their managed care and fee for service sides as well. Communication is a big one, making sure that services are similar across the board between managed care and fee for service is a major issue and concern in Colorado. That's one of the areas in which they fell short. And so Oregon has been working very diligently to make sure that our communication and services will be as similar as possible.
Thanks, Jessica. Any other questions or raised hands? Okay, I'm going to pass it to Dawn for any last comments before we go to break.
Thank you. I know many of you must have seen the announcement that our director, Pat Allen, has left the agency and is sorry, and has taken a position as the Cabinet Secretary of Health in New Mexico. Our new director, James Schroeder, will officially join the agency today, and officially joins today. And so we look forward to hearing more about this. He has come to us from HealthShare, where he was the CEO, and he also is a physician assistant. So we'll have a clinician in that director position. So we look forward to working with James to understand his vision for the agency. And also, I wish to extend my gratitude and congratulations to Pat for having done an incredible job of managing through an extraordinary time in the agency's history, and for setting us up to take on the challenges of the new ways of delivering care that we need to evolve into, and helping us frame the central questions, particularly around equity, in a way that help us ground for the work ahead, even in the wake of his departure. So please join me in our celebration of the work that he has done with us, the work that he has enabled us to do when he has gone to bat for us to be able to do this in the ways that we think are the best ways to eliminate health inequities across the state. Thank you for all that you do to deliver care across the state. Roger, I see that your hand is up.
Yeah, I just wanted to circle back to Jeannie's question about ADHD. And we did perform an evaluation that included some CCO data and presented it June of this past year. So short memory, maybe I need the new Alzheimer's drug, But anyway, I put a link in the chat if people want to go see that DUE, and it might give you food for thought for collaboration and moving forward.
Thank you, Roger.
Thank you, Roger. And I think that brings us to Lisa. Take it from here, please.
Thank you, Dawn. So yes, as we, start a new year and we start a new leadership and direction, it is a time of change and time of refreshments as far as where we're going. And, hopefully we're also in a new year of not a lot of COVID. I'm really hoping Ariel's not going to give me another slide deck where it says COVID deck and here's new COVID codes. So let's cross our fingers, people. I echo Dawn's comments. Pat has brought us into a new strategic direction where health and equities is a place. Obviously you've all heard me talk about health equity before there wasn't even a health equity plan. So I echo Pat's leadership in that space, and I will continue to push you all there. So, whether Pat's here or not. So you all know me anyways. So that's where we're at. I'm going to go ahead and let's break for what is like, I don't know, 7. We'll break. Let's come back about a little bit about 11:15ish, and 11:17, I guess. 11. I don't know. Do math. 11:18. 11, and we will come back and do breakout room, and I'll explain it out. We'll do it very similar to what we did before. We're going to talk about EPSDT implementation, since you all are in the thick of it, but you'll do it in small group, and we'll give those instructions when you get back. So go take a stretch break, bio break, do what you need to do, leave your computer, and we'll see you in about 10 minutes. Thank you.
Thanks,
Hey, Lisa, aren't we doing HERC update before the breakouts?
Oh, never mind. Yeah, you're right. Never mind.
I'll be really quick. I'll try to be super quick.
Oh no, we're doing HERC and a breakout room. So HERC, Ariel is like, please don't forget me. So come back in 10 minutes for HERC. Don't forget HERC.
Thank you.
Hi, Ariel. When we see Dawn, maybe we'll start. I see Jeannie, but I don't see Dawn. Oh, there's Dawn. Everybody's back for the party. Let's go ahead and do the HERC. Jennifer's on, so she can just go ahead and advance slide when you're ready.
Great, thank you. Thanks, all. I'm Ariel Smits. I'm the medical director for the Health Evidence Review Commission, and this is the HERC update. Hasn't been a ton change from the December update, so I will try to be quick because I know you guys have breakouts you're all looking forward to. So if you could go to next slide. Sorry, Lisa, there are new COVID codes today. So there are 2 new sets of COVID codes for the pediatric vaccine boosters, and these are all open currently. So just FYI, you all need to make sure that they're open in your systems. So there you go. And just as a future FYI, there may be an RSV monoclonal antibody-ish thing coming down the line. So just keeping your eyes out for that, hopefully in the future. Next slide. So our behavioral health advisory panel is actually meeting today. I guess I put the wrong date on it. It's not the 10th, it's the 9th. They're meeting this afternoon. It's a virtual meeting, and you're all welcome if anyone wants to sit in on that meeting. They are going to look at the 2023 HIC picks. There's a set related to behavioral health and SUD. We're just basically getting their input and making sure that we're getting these right. They appear to be some expansion to more types of providers, et cetera, as well as some chronic pain management codes that CMS is trying to get folks to use to do wraparound services. We are also looking at our urine drug screening guideline, and this is at a request from industry, but it looks kind of pragmatically like we may end up opening a new HCPC codes, which would be for 8 to 14 drug classes. And that's really just to match Washington and Idaho so that folks who practice near borders don't get really confused about what they can bill. I don't think there will really be a significant change beyond that. We already actually are somewhat generous in what our frequency is for urine drug screening and what we allow compared to a lot of our sister states. So, but we will be talking about that this afternoon. So if anyone has any input on that, you are welcome to attend that meeting. Next slide, please. EBGS will be meeting on Thursday, the 12th. They are going to be talking about continuous blood glucose monitoring, bariatric surgery, biomarkers for cancer, and chronic disease self-management programs. A lot of really just their sort of scope statements, et cetera, on a lot of those. But if you are interested, again, that's a public meeting. Feel free to jump on that one if you're interested and have any input. And as usual, EBGS is always interested in topics that you feel would be appropriate for the coverage guidance process. Next slide, please. VBBS and HERC will be meeting on the 19th. Also virtual meetings, also open to the public, and you are welcome to attend. Our usual consent agenda. We are talking about HSG. There was a question about whether there was some times where this would be appropriate as a diagnostic test. I think having a conversation with some of the medical directors, we think it probably should remain excluded, but just so you're all aware, there may be an appropriate time. They're probably rare cases, but these could be something that you could grant as an exception. We're going to be talking about other HCPC codes that are coming out. The big one, there's actually 70 some that just got released, just for your information. After our meeting, we will post those to our website as a Excel spreadsheet that you're welcome to get to. And also just FYI, we are actually going to have a February 1 list. Sorry, I know it's a lot of implementation on your all side, but there are so many HCPC codes that, and some of them are pretty important. They seem kind of minor, but they're the AMA and CMS are kind of in a fight over what constitutes extended services. And the CMS is coming out with their own codes for extended hospital services and extended office visits, et cetera. So you could use those instead of the AMA CPT codes. So just realizing that those are in this big set. For the HERC's work, it's not that important because we typically want you to do extended care if that's what's necessary, but just to be aware that these are different reimbursements and might be really important to your providers. Like I said, we will once the HERC approves them, we'll have them available on our website as an Excel spreadsheet that you can download, and also to be able to realize that they are currently open and available. The other couple things that we're going to do, we're going to add some cardiac testing, cardiac catheterization sort of add-on codes that we thought were appropriate with our cardiology colleagues. There is an operating room anesthesia benefit for dental care providers, which is probably an important one for your dental groups to look at, and then some remote behavioral health codes, some of which are recommended for coverage, some not, depending on what they are. We'll talk about our BHAP report, whatever they have decisions on our meeting today. Next slide, please. Other topics, probably recommending adding, or probably add coverage for IUDs for certain circumstances for endometrial cancer. It's not standard of care, but it's an option for certain people. We are updating our cochlear implant guidelines mainly for what the definition of hearing loss is. We have been asked to look at unilateral deafness. The recommendation is to continue coverage for only bilateral, but just to be aware that that is an issue out in the community. We're looking at Afirma genetic testing on thyroid biopsies and 4K biomarkers for prostate cancer. Both of those we're recommending continued non-coverage. We are updating our urinary incontinence surgery guidelines just to bring them kind of up to current terminology and working with a gynecologist about that. We are going to propose adding coverage for prurigo nodularis, which is a very itchy, disabling skin disease. It will be part of our inflammatory skin disease guideline. One big topic of conversation that I'm not sure will actually have an answer for at the end of this meeting is our tobacco cessation prior to elective surgery. There's been a lot of questions raised about our requirement that there be objective measurement of tobacco cessation prior to certain elective surgeries. So we are going to look at that. We're going to look at our requirement for 2 objective tests prior to certain surgeries as being logistically difficult for some PA process, and whether we should continue to require 2 or just require at least 1. And then lots of other questions. How do we define a current smoker? How recently do you have to have quit, and with what kind of documentation before we don't require objective testing? There's just lots of different moving pieces here. So just we're going to be discussing this all. And I know this has been really important to you all, so I just wanted to highlight it for you. And then we're going to add explicit coverage for 12 months contraception prescriptions. Next slide, please. These are upcoming topics that are on future agendas. They may or may not appear at the March or May meetings. We're kind of working on them. Facial angiofibroma, probably not going to bring that. It was brought to us because we have this has no effective treatment. There is now a FDA approved drug, but they're not giving any rebates. So we are unable to offer that drug. So as far as Medicaid's concerned, there's still no effective treatment. Looking at some expanded coverage for what would not be traditionally considered a type 1 diabetic, but are people who are missing a pancreas or don't have a functioning pancreas, but it's not autoimmune, so they're not type 1. There's lots of different nuances there that we're working through. Tonsillectomy for recurrent infections. We've had pediatric ENT reach out and say that our current guidelines aren't matching the ENT guidelines. I am having significant problems understanding the current the otolaryngology guidelines. If any of you have a helpful peds otolaryngologist who could help me, I've tried reaching out to a few and haven't gotten a lot of feedback, but I would be happy if anyone could connect me with somebody. We've been asked about pulmonary rehabilitation and long COVID. We're not going to bring this topic up unless we can figure out whether or not we can actually limit coverage for long COVID in any way. I am working on our organ transplant guidelines. This is a kind of a long, slow process with a lot of reaching out and prodding people. So that's probably a long-term project. We are also looking at different ways to screen for breast cancer, but we're waiting for the USPSTF review that's expected out this spring. We're also looking at non-24-hour sleep-wake disorder and sleep light therapy, et cetera. That's kind of an ongoing project. And WPATH 8 came out last fall, as I'm sure you're all aware. So one future topic that will be a big topic that will require probably multiple meetings is our gender affirming care. There's also multiple other things in the hopper. And as usual, we appreciate anything that you bring up that you feel that we are not doing correctly, or that you want us to look at, or that you have questions from patients or providers. Next slide, please. The HERC will also meet on the 19th. They are going to be looking at QALYs. We've been working with some stakeholder groups about QALYs. We don't really envision that we're going to what exactly our final product of this whole discussion is going to be. We're basically probably going to just update the HERC on our ongoing discussions here. And then they're going to look at the chronic disease self-management program scope for EBGS. So, and then of course the VBBS report. Next slide, please. Again, we always are interested in what you all have concerns about or questions or what you want us to look at. So feel free. The herc.info is the generic email that will always get to somebody. And you're also welcome to send things to me directly or to Jason or to Amy. Any questions for me? I know that was really fast. I was trying to keep you guys sort of on track.
We've got time. You've got more COVID codes to throw out, I'm sure.
Oh, I'm sure there's going to be by next fall, there's going to be like a flu COVID hybrid, and that's going to need all its codes. And then
there's going to be new COVID treatments, I'm sure. So, I mean, there's going to be more COVID codes for, years to come.
Well, then what is the new one that is becoming like this huge issue suddenly? I think they're calling it the Kraken. I just love that name.
Isn't that like from some sci-fi movie? But that's a whole tangent. Jeannie?
Yeah, hey, I just want to say I'm thrilled about the 12 months of continuous birth control coverage and having that out there. That's very, very helpful, especially in our current national state and the role that Oregon is playing. I'm curious if that will then translate, and I'd love to hear from some of the CCOs. And we didn't talk about this in our COMED meeting, but if that may translate into the coverage with our CCOs, then yes, 12 months, but could we then mail out 12 months of pills rather than sending out 3 months and a 90-day supply? Could we then, since this is a chronic medication, mail order, could we then do 12 months? And I'll look at this with my own pharmacist and our own mail order, but just curious if anybody else sees that as maybe a possibility going forward and more advocacy for our members.
That's what the statement of intent will be, that we intend that you cover 12 months at once. And I think it is a statute for non-Medicaid programs for sort of private insurers. And I believe they have to dispense 12 months at once, but I am not a legal expert. So I don't know if Dawn, if you know more about that.
I don't either. If anybody, it looks like Kat does. Go, Kat.
I don't know more about that, but I did want to share just some information that we learned as we were exploring this, which is that there's kind of just an operational thing that's a little bit of a problem, which might just be an educational piece for those who are prescribing or filling the medications, because a lot of people actually need 14 months worth to get 12 months. And so some of it is that people are not actually receiving 12 months worth because they need a full 14-month supply to get to the 366 days, especially if you're doing continuous. So that was just a little operational, I don't know, gold nugget that we learned. But a lot of that is really just around, I think, education around prescribing and then filling it to make sure it's for the full day supply of a year.
Actually, Kat, that's a brilliant observation, because I'm just wondering if we need to even change our guideline wording to say, this may include more than 12 packets or 12, additional medication if you're on continuous cycling may be required for coverage, or whatever words we're going to use.
That would be ideal, so that anybody who's then looking at working with internally could give the adequate amount. Providers can write the correct prescriptions, but filling it, us as CCOs can then make sure and fill that 14 months as well. Bhavesh, go ahead.
Yeah, I'm just want to be a little bit cautious in that it shouldn't happen when something's first being prescribed. Everything is great when things are stable, but when providers go out and just give 12 months right off the bat and somebody's not established on something properly and they start to have side effects, we have a lot of wasted meds.
Yeah, and our guideline says that after a 3-month trial.
Okay, thanks.
Great. Questions for Ariel? I made a note about the 14-month thing, Ariel. We can also circle back with our.
Yeah, and I'm actually sending something right now to our team, just so I keep track of it.
Great. Then I can take away my note.
You can keep your note. That's fine.
Okay. We're just double duty it. Any other questions? Okay, thank you, Ariel, yet again. We will transition over, and Holly Joe wins the prize for knowing the Kraken. I wasn't quite sure what it was from, but she's Pirates of the Caribbean. Thank you. We are going to transition over to large group. This is just an old slide, so go ahead and just take that down. We can just not share the slide deck anymore. And we are going to go into breakout rooms. I will drop the questions into the chat stream before I send you into breakout rooms, because we learned that they don't really go, they just kind of like highlight at the top of the screen, and you can't really like copy them down. So I'm going to drop them. They are on the agenda, they're on the slide deck, but if you don't have access to that, then it's really difficult. So I'm going to drop them over for y'all here in a second. Jeannie, do you want to go ahead and tee it up while I do that? Kind of what we were thinking of. What we were trying to do was honor the conversation about having time for smaller groups. What we heard was breakout rooms are good. Doesn't mean that we're always going to have breakout rooms, but where it's kind of relevant, we're going to mix it up a little bit, do breakout rooms, do learning collaboratives. For this first month here, we thought breakout rooms would be great. Jeannie and the chairs, Laura, Doug, Dawn and I were talking, and we teed up EPSDT for it. So Jeannie, you want to lead off with that, and I'll start getting some logistics started.
Yeah, no problem. So I think after the last meeting, it was clear that the small group discussions were pretty helpful on putting forth good ideas in general. I won't judge them and say whether they're good or bad, but we put forward some ideas that were to be discussed with a larger group, and there was feedback that provided a nice environment for everyone to contribute. So we thought we'd do that again. And then when we were talking about different options for topics, it seemed that once again, the EPSDT rose to the top, as this is what a lot of us are working on. And then we thought that we would, in our small groups, talk about how does each one of our CCOs, whether you're in behavioral health, physical health, or dental, how is this implementation going? What are maybe, and I think Lisa's going to put the prompts in the chat that I had sent, but what how is that process going kind of in general? What do you see as the biggest barriers? And I think, what was the other one Lisa, successes? What are you doing to implement? What is your process, and what are your biggest challenges? So yeah. Anyway, I'm hoping that we can generate some discussion and then bring back some information for the group to discuss as well.
So just a couple process kind of things for breakout rooms. It'd be great. Just introduce yourself. So some of you may not know yourself. So just at least just say howdy, hi, here's my name, here's my organization. It'd be good if you could just take a note taker. I will do very similarly. So just take the notes. If you send them to me, I'll synthesize. It's only as good as if you share the information. So feel free to share. I'll again summarize. I'm not disclosing any one CCO's. This person said this person said that. I'm just summarizing for lessons. So I'm going to submit you all to your breakout rooms now. It's in the chat. So if someone can, hopefully you can see those. And again, idea, thank you, Jeannie, is to be productive and collaborative. And here you go. Fire, you're all here. You should, it's random, by the way, random.
When do we come back?
I'm gonna probably pull you back usually like about 10 minutes, so 12:20. So you got a good over half hour, little about over, and I'll send you a little chat warning, 5-minute warning, 1-minute warning. So you got about 35 minutes. Random assignments. Hello. Everyone will be shortly joining in less than 30 seconds. There's a countdown on my screen. The power of Zoom brings everybody back. Welcome back, everyone. I have a question. Did you virtually hear my voice broadcasted? Okay, that's just number one, slightly creepy. But number two, that's a new feature of Zoom Government. I got a Zoom license, so apparently it works. If you were able to hear me in the Zoom breakout room. So that's kind of cool. Thank you for confirming that. I will let our partners across the agency who have Zoom know that. So thank you. For those that are coming back from the breakout room, I think we're all back. We are joined by Jessica. So Jessica has come back with us now, your other policy analyst for EPSDT. So thank you for joining. So I'm gonna let, I think we had, I don't know, 4, maybe 5 breakout rooms. Dawn/Jeannie, I'll go ahead and we'll do it like before. For those who took notes, if you wouldn't mind, just email it to myself. I will go ahead and, like I said, just kind of collate for themes. You guys are usually, again, very, very pretty consistent about what happens in the breakout rooms and where you all are at just on those barriers. So if you wouldn't mind just dropping those over, I'll kind of create some themes and put together just a mini slide notes of where EPSDT is at across the CCOs, just so you have some of those thoughts. And then it does help Laura and Dawn and Jesse as far as some of those policy areas of where those barriers are to think through and really kind of, I don't know, help think of through those barriers. So send your notes to myself, Lisa Bowie, and I'm going to open it to the floor for any of those brave souls who want to take first. Raise your hand or put it in the chat if you want to open the floor for sharing your group's comments. Who wants to go first? Jeannie just put hers right in there. Jeannie, do you want to speak to it?
Because I don't like to email later. I can't guarantee that it'll all get done. If I have a moment where I'm getting things done and being efficient, it's got to come to you now. So copy and paste that, please, Lisa.
I will do that. Do you want to give the high points?
Yeah, I think in general, we are all feeling that the gray area with broad coverage and where that coverage would be open to interpretation is definitely a challenge. And we're going to seek guidance internally and externally from the state to help overcome that challenge. I think clear guidance from the state on kind of what so far, maybe the path of where is fee for service in implementing these EPSDT changes and what are those changes being made. For instance, we do know that from the last guidance that we got was that there were, they are going to pen some claims, I think, for 2 weeks and ask for some medical records. So we know fee for service is making some changes in this EPSDT area. So the question is, can we get a bit more guidance on what other things fee for service is doing? Are you adding PAs in some particular areas? Or how are you kind of accomplishing this work there? And then HERC guidance. I think the guidance of what was below the line before now coming above the line, can we have that in a clear, will there be a clear kind of document about those changes separate from kind of regular updates and changes that happen with HERC, right? Because we're gonna have the behavioral health codes, we're gonna have some regular updates for other areas, but can we specifically get EPSDT updates and changes from the HERC that take place that are going to be added? Which conditions were brought above the line so that we make those coding changes on our own for our claims review, et cetera, because those will go right through and pay. Those kinds of guidance from HERC and fee for service would be really helpful. Work process, pretty consistently CCOs are looking back at denied claims in 2022 for kids, right? What was denied? What service areas made up those denials? What do we do with those now? Are we looking at those and saying, well, we're just going to automatically approve those, or do we need to put a PA in place for those services, because those services really do need medical necessity review, or these other ones are kind of like low barrier acne meds? Do we just do something like we did with pharmacy, where we say, okay, maybe some of these acne meds are now going to be on formulary? Just some changes like that. So pretty consistently, the CCOs are looking at what was denied in the past to see what kind of impact this will have going forward. I think that process is pretty consistent. And then our questions: what is fee for service doing about PAs, that kind of thing in the EPSDT area, to the clarification from HERC on what's coming above, and can you please put that separate from the regular updates or separate documentation? 3, does HERC make comparisons on these evidence bringing the EPSDT above the line with other states? Or is a lot of this work being done just within kind of Oregon, or is HERC looking at evidence base coming from other states and what they're doing in the EPSDT realm? And lastly, but not least importantly, who is our go-to to have these conversations when we have questions at the state? Who do we, we feel pretty strongly in our group that it needs to be, it's not necessarily, it's probably a combination of a project manager who's living, eating, breathing this work, but also somebody in charge who makes decisions in this EPSDT realm, so that the CCOs feel that those questions can be taken to the right people and have them addressed. And pretty quickly, we did get the feedback that some of the questions that had been submitted to the state were taking upwards of 2 weeks or longer to get some response. Now, it's been holidays. There's all sorts of reasons why there may have been a delay, but just making sure that we do get some timely responses back. Team, please speak up if I missed anything.
Thank you. Anyone else? Another group?
Hey, Lisa, it's Doug Luther. I'll speak for our group. Just
Thanks,
really
Doug.
quickly. Jeannie sort of covered most of the stuff that we talked about, but maybe 2 issues to emphasize. One would be the idea of learning from what other states have done. If all the other states have already implemented this, can we get a little more clarity and a little more detail on how other states have implemented EPSDT? Is it always the same? What have they learned? How do they define medical necessity for certain cases? Things like that. And then the second was, what I didn't hear Jeannie mention, was any financial analysis that's been done thus far. Both obviously would be predictive at this point, because there is concern that services that have been denied previously, providers have learned over time to not submit those. So there may be this sort of hidden demand, if you will, going forward once we start covering certain things. And that's, of course, very hard to estimate. But then that would sort of suggest that maybe some ongoing monitoring of the financial impact of this over time would be advisable.
Okay. Thank you. Laura, Jesse, before I forget, remind me to circle back. I know you guys mentioned Maryland. I happen to know some people in Maryland, so we can touch base about that. Next group.
Hey, Lisa. I was from group 5. It's Laura Matola. And we had some really good conversations. Some of the things that we talked about was looking at how to handle the new PA requests and come in, and how to, just how to reorganize the prior authorization process for the kids under the 20 years of age. We talked about opening up some services and stuff so that reduces some of the admin burden on the CCOs. And then also on claims, doing some retrospective review on some of the claims. And then we kind of talked about difficult areas like, you know, how are we going to address like orthodontics, and you know, are there any other areas of services that that have been previously covered but more limited in access or use, and do they anticipate to see an increase in some of those services, especially if they have limited access to begin with, such as ABA? And then we talked about the data analytics of it and looking at what was previously been processing in 2022 versus what's going to be coming in 2023, and trying to do some comparison there. And then we also had conversations about, you know, the funding and how are we going to pay for increase in services and stuff that were not may not have been previously paid for in the past. So that's where we kind of landed in ours. And then also a little bit of the talk was about what is happening in other states, and having that question being asked was really nice.
Thank you, Laura.
You are welcome.
Any other groups?
I was in group 3. This is Dawn Mautner, and I'm happy to speak, but I wanted to circle around and cover a couple of things, answer some questions that came up, and so I could wait until the end to do that. But the questions that came up were primarily prior authorization and how it can and cannot be used. That's one. It cannot be used for screening services, but it can be used in utilization management and the ways that we have traditionally used it, just not for screening services. And then most of the rest of the questions were about handicapping malocclusion and the workforce, the risk corridor, the complexity of sort of the managed care billing with dental services, which haven't necessarily done as much with global services. As an example, more on the historical fee-for-service model, and of course eligibility. Group, anything I missed that you want to bring up? I see that Jessica posted a link in the chat with the appendix document that names the HERC info on what was moved above the line from the 27th of December. And Jessica also posted the epsdt.info email, which is the primary contact. It goes to the team, Liz and Jessica and others, Laura, and they bring in medical personnel or whoever is needed to answer questions through that email. Laura?
I was just going to add from our group, because a lot of folks have mentioned the prior authorizations, and I think Kat suggested it would be helpful to, I don't know if it's this forum or the operations committee, but to learn from each other about how CCOs and I would say fee-for-service too are rethinking PA. Are there particular services or things that you've decided to remove PA for because they're almost universally approved? What things are different CCOs learning and doing to kind of ease the administrative burden of the reviews? And the group suggested, I think that after a quarter of implementation, that may be a good time to revisit that and find out what people are doing. Just throwing that out there.
That would be great. The same is true for fee for service, figuring out what we need to be PAing and what we need to not be PAing. It would be great to have a broader discussion about that.
Okay, we are actually at time. I'm sure people's getting ready for lunch. What I just made note of is a little bit and a lot about PAs, prior authorizations. Part of it is process, part of it is timing, part of it is about administrative burden, part of it is what and when. So I also just made a note is after implementation kind of gets going a bit, maybe revisiting this topic specifically about the PA process, because then you'll know a little bit more, and each CCO is implementing it probably slightly different, bringing it back maybe after a quarter to this group. It probably sounds even more so less in the QPI session, more in this morning session, because it's probably not just the quality folks that do the PA process monitoring, but more even the med doctors who are part about and the whole thing. So we'll probably put it in this morning session, probably in one of these breakout. So I made a note of that. Hopefully you all found this to be helpful in the format and in the function of the discussion. If you didn't, send me a comment. If you did, send me a comment. I put in the chat for everyone. If you did not receive the 2023 meeting series, some of you already have done it, email me. I'm cleaning up the email list yet again. Then the internal folks will get the rest of the 2023 series. The external folks, you should have gotten it. If you didn't, let me know. So either way, send me a note. I'll be doing some more cleanup, but everyone, please have a good rest of your start of the new year. I will collect the EP SDT notes, and like I said, synthesize it, put some notes out in preparation of our February meeting. I will get them obviously over to the EP SDT team, and we will meet with the chairs and start working through the rest of all those things that we talked about in December in preparation of this coming year. Everyone have a good rest of the day. Jeannie, Dawn, any last minute comments?
Nope, appreciate everybody's involvement.
Happy New Year, everybody. Thanks for riding this ride with us.
Thank y'all. Bye.